How you doing, everybody? This is Gary here, the marketing guru at Gentle Wellness Center. I am joined by David Javdan, who's the president of Gentle Wellness Center, and the amazing Joseph Shaw Jones, who is the medical director of the cancer program here.
Good
So in
morning.
this, so in this particular series, we're here to educate you on alternative therapy or alternative cancer therapy, and also give you something else to do than watching CNN, because we're all here stuck at home because of this coronavirus, and I'm sure you need something else to do. So you might as well learn about alternative cancer treatment and its benefits. So what I'm going to do, I'm going to let David take over here.
Thank you, Gary. Like Gary said, Gentle Wellness Center, we're located in Fairfax, Virginia. We are an alternative integrative cancer therapy center with Dr. Joseph Shaw Jones, our medical director. Dr. Jones has been practicing alternative cancer therapy for the last 12 years or so. I will be interviewing and asking him some questions relevant to his work and what he's been doing and his experience treating cancer patients. I think the first question I'd like to start out with is the type of cancer therapy we do here, which is, again, different than conventional cancer therapy, is called insulin potentiation therapy. It's one of the main types of alternative therapies used for treating cancer, which we specialize in here at the Gentle Wellness Center, and is what Dr. Jones practices. So I think my first question for Dr. Jones would be if you could explain in layman terms what alternative cancer therapy and specifically insulin potentiation therapy is.
Great, thanks, David. There are a number of alternative cancer therapies that are available, and they go from a range of patients who are doing totally alternative, natural therapies that include nutrition, supplements. There are dozens, truly. What we offer is a way of administering more conventional medications, but given in a way that is not so toxic to the patient. I use the same drugs that your regular oncologist would use, but I dose them lower, but on the other hand, administer them more often in an effort to lower toxicity associated with the medication. We also use a medication called insulin, not because the patient is diabetic, but we use it with insulin at low levels appears to increase the tissue permeability for the chemotherapy. It's easier for the chemotherapy to get into the tumor cell in the presence of low doses of insulin. Now, this is this idea was researched and promoted by Dr. Perez Garcia, Donato Perez Garcia, and his grandfather a couple of decades ago, and has gained more popularity in, I guess, the last five or 10 years. There have been more patients who are seeking some alternative that isn't as toxic as conventional therapy has been. We, again, use the same drugs that your conventional oncologist would use, but we use a lower dose and give them more often. Usually, patient comes in and they need chemotherapy. The doctor's going to recommend a protocol that is administered at full dose every 3 or 4 weeks. What we do is administer 20% of that dose on a weekly basis. So your average patient's getting between 70 to 80% cumulatively over a month's time. They get about 80% of the dose that they would receive conventionally. But by breaking that dose down into weekly administration, the side effects associated with those drugs, such as hair loss, nausea, vomiting, bone marrow suppression, are the major ones, nerve damage, heart damage. those things are mitigated up to a great degree by administering at a lower dose. We've known for some time that administering chemotherapy in this lower dose, more often manner is far less toxic. What's, I guess, newer about it is using insulin prior to administration of chemotherapy, in hopes of helping to get the drug into the tumor cell.
So Dr. Jones, insulin potentiation therapy, or IPT as we call it, allows you, the doctor, to inject insulin, in this case, to your patients, like you said, allowing those cancer cells to easily absorb very low dosage of chemo drugs, in this case, that would allow approximately the same type of effect with the patients, or the end results would be the same as your conventional therapy. But overall, if you were to tell us what the benefits of IPT is, why should patients come to us doing IPT versus going to a conventional oncologist?
Well, what I hear from the patients that come in, these are patients that have either been treated before and had a bad experience, or have had recurrence, and the recommended protocol by their oncologist is more than they want to go through, or they've had a loved one who has had a really bad experience with treatment. It's uncommon to have a patient die from treatment. It does happen, but more often than not, the patient will just have such untoward side effects that I have heard patients come in and tell me they would rather die from their malignancy than receive conventional chemotherapy. Many of the patients will come in wanting to do only alternative therapies as nutritional recommendations or supplements, or things like high-dose vitamin C. Those things play a role, but their main role is improving quality of life. To actually attack the cancer, we need to use what are essentially poisons. Part of my job is explaining to the patient why that's necessary, and how we can do this without making them quite so sick as they would being treated by their conventional oncologist. Now, all patients understand, after having visited us, there's one thing I make very clear, that the best known treatment for their malignancy is what their conventional oncologist is recommending based on large-scale studies. But if the patient is unwilling, or flat says they cannot or will not do that form of therapy, what I don't want to have them do is opt for something that I know will make them perhaps temporarily feel better, make them subjectively better, but not really address the tumor itself. And that's where we do need to use toxic drugs. The idea is to administer these drugs in a way that isn't so toxic.
So Dr. Jones, as you mentioned, obviously both radiation and chemo drugs are toxic to human body, and obviously the human immune system starts fighting these drugs, and it will overall degrade the human immune system. What steps or what measures do we take here at Gentle Wellness Center to improve or maximize the immune system in conjunction with these low dosage of chemo drugs that you give to patients?
One of the more popular therapies is high-dose vitamin C. We're using on the order of 50-gram doses, intravenous vitamin C, administered on a weekly basis. Kansas University has done most of the research on vitamin C. The Riordan Clinic, they're recommending twice weekly 50-gram doses. Vitamin C is quite expensive, and many of the patients will opt to do vitamin C on a weekly basis rather than twice weekly. But we do recommend that. Also, the hyperbaric oxygen chamber is another modality. Now, with the chamber, we're not actually treating the malignancy directly. All the FDA indications for hyperbaric therapy is directed at wound healing, accelerating skin graft healing, tissue healing. Well, one of the tissues that's most important in cancer treatment is the immune tissue, which is distributed throughout your body. Delivery of high levels of oxygen, not only in your red blood cells, but in your plasmas, which what happens when you're in the chamber. Your tissues are able to use that extra oxygen to make more energy. They use that energy for repair of damaged tissue. And there's evidence that good stem cells, the very primitive cells that are in our bodies, can differentiate or mature into cells that can replace damaged tissue. That's the goal of hyperbaric oxygen therapy. We also use the far infrared sauna. There are two roles with the far infrared sauna. One of the goals, of course, is to get in there and sweat. This is a box that has a footprint a little bit bigger than your refrigerator. It's as tall as a refrigerator, and it's about 140 degrees in there. And we acclimate the patient to that, but the goal is for the patient to sweat. If they're sweating, we know that their core temperature is up a degree or two, which helps to a degree with some tumors, especially tumor cells in circulation. Also, you'll be sweating out toxins. Now, what toxins? We know that toxins that can be measured in the sweat easily are things like heavy metals. There are probably other toxins that aren't so easily measured that are being sweated out at the same time. So we do that. And then there's some supplements that we recommend that appear to have anti-cancer properties. Things like curcumin is one of them. I also like to use a couple of medications off-label because of their immune modulating or anti-cancer properties. One of them is naltrexone, given at low dose, LDN, at 4.5 milligram dose. Now, what LDN does is it interferes with the feedback mechanism of your central nervous system in maintaining endorphin circulation. Kind of fools your brain into thinking there are not enough circulating endorphins present. So your brain will kick out more endorphins. Your immune response to those higher levels of endorphins is to increase natural killer cell number and function, cells that will help fight the malignancy. There was a clinical trial that looked at this some years back, patients with multiple myeloma. One group got chemotherapy, the other group got chemotherapy with LDN added. This is a compounded pill taken at bedtime. The group that got the LDN with their chemotherapy did statistically better than the group that got chemotherapy alone. So we have clinical evidence to support its use. That runs about $45 a month from a compounding pharmacy. The other medication is metformin. Now, metformin is a diabetes drug. The reason we do that is it has its own intrinsic anti-cancer properties in cell culture. Also, it modulates hepatic or liver, the dumping of stored sugar in your liver is moderated by metformin. Metformin also makes sure it's not insulin, and it doesn't make you make more insulin. It makes your body more sensitive to the insulin that you make. So normally you go to eat a meal, your glucose levels would rise, insulin levels would rise to bring your glucose down. Well, in the presence of metformin, your insulin levels do not rise as high, and your blood glucose levels will come down to normal faster. There are no side effects at the doses that we use. And metformin is quite cheap, just a few dollars a month from any pharmacy. So it's off-label use of medications. There is recent popularity in using a number of medications off-label, hoping that or believing that these medications may have anti-cancer properties. There I'm talking about medicines like doxycycline, atorvastatin, I mentioned metformin. One of the worm medicines, that medicine, what was that medicine? Not ivermectin, but mebendazole. Mebendazole is used to treat roundworms. It has not been studied extensively for cancer purposes, but there was an anecdotal report. Someone in the healthcare industry had metastatic lung cancer, I believe, took mebendazole and had remission. Well, a lot of interest there, and I know that that drug's being studied heavily. But there are a number of medicines that patients are on their own able to take off-label. And we don't know yet if that's certainly a recommendation I don't have yet because the data's not there. But there are a number of medications that are out there that may prove to be of benefit.
Thank you, Dr. Jones. Just going back to what you mentioned about the far infrared sauna, what is the difference between a far infrared sauna and a regular sauna? Obviously, both of them will heat up to approximately 130 or 140 Fahrenheit. But what is the difference there between?
Yeah. Well, it's described as dry heat. It's a form of electromagnetic radiation, far infrared part of that spectrum. Its energy is absorbed a little deeper in your tissues. It's believed to be more effective than, say, a steam sauna, where that heat energy is more superficial. That's the theory that is behind using the infrared sauna as opposed to another form of sauna.
Wonderful. And Dr. Jones, can you tell us what types of cancers can we treat here using this methodology?
There are a few cancers that we can't treat with IPT. There are some that are difficult to treat and shouldn't be treated on an outpatient basis. There I'm talking about acute leukemias. Certainly any patient that would be getting in process for a bone marrow transplant, of course. Those patients would need to be, those patients really need to be in a more intensive care setting where you need a lot of lab work and a lot of observation of the patient during that time when their blood counts are really quite low and the doses of medication used to affect the treatment are quite high. But it's been my experience that tumors that respond well conventionally respond well in our hands. Tumors that don't respond well conventionally don't respond any better with IPT, but we are able to get treatment in that, again, in a less toxic manner. The most common tumor that we treat is breast cancer, followed by prostate, GI cancers, lymphoma, bladder cancers. Probably the two malignancies that I would steer patients more strongly to conventional therapy rather than IPT would be patients with the leukemias and patients with multiple myeloma. Most other solid tumors certainly that respond well conventionally respond well in our hands too.
Very good. And so, Dr. Jones, how would you describe the process for a given patient as they come in? What is the overall process as far as how you go about implementing this IPT methodology?
Yeah, after a patient schedules an appointment, we obtain all the records from their previous treatment. I review those, get the patient in, update their history, do a thorough physical exam, and then based on their tumor type, the recommendations of their oncologist, because before I'll treat any patient, they have to have seen an oncologist and understand what is the conventional recommendation for them. Based on that and the National Comprehensive Cancer Network's recommendation for a particular treatment protocol, I'll develop that protocol, but at doses about 20% per week of a conventional protocol based on the full dose recommendation. The patient will need to have a recent scan as a baseline, a staging scan. If something's been done within a month, then that's usually close enough. We also need to be certain that we get the chemotherapy into the patient's blood system and not under their skin. So there are a couple of ways of doing that. We schedule patients to have something called a Metaport placed. It's a device that's like a stack of quarters with a soft well in the center and a little catheter that comes off the back end. Patient is mildly sedated. They go to an interventional radiologist to have this done, but it's an outpatient procedure. It takes less than an hour to do it. They mildly sedate the patient, make a small incision, place this device under the skin, run the catheter into one of the larger veins, run deep, and then they oversew it with some absorbable suture. The day after this is in, then we can access that port, and all the treatment will go in via the port. Now, this device is put in under sterile conditions, and when we access it, when we put this special needle that goes into the port, that's done under sterile conditions too. Now, the beauty of this is the patient doesn't have to be stuck so many times, because patient, if they're also doing vitamin C, that is an injection that we have to put it into the vein if they don't have the Metaport. We need blood work a couple of days before each treatment to see what their blood counts are doing. That's another stick. IPT itself has several injections associated with that. So usually after a couple of weeks, it's very difficult to get a sure access to a peripheral vein like in the arm. So that's why we really need the Metaport. The beauty of the Metaport is when you're through with it, a small incision can be made, it can be taken out, thrown away, and you're left with a small half-inch scar that heals normally. When the procedure is done at a center that does a lot of them, I rarely see a complication in doing the Metaport. Patients, once they have the Metaport in, they think it's great. You can do virtually anything while you have the port in place. You can scuba dive if you want, everything but contact sports, really. So they need the Metaport. We schedule the infusions for weekly. Patient fasts for 6 hours before they come in for the infusion session. When they come in, we administer a small dose of rapid-acting, short-acting insulin based on their blood sugar and their body weight. And we follow their blood sugar to where we get to as low as it's going to get with that given injection. We aim for a blood sugar of about 60. We used to routinely drop people down into the 30s for years. That's what we did without any issue. But Dr. Garcia's latest recommendations were for a blood sugar of 60. So we aim for a blood sugar of 60. It takes 25 minutes for that to occur. Once your blood sugar has reached this therapeutic moment, and when I say therapeutic moment, that's at the point where all the patient's insulin receptors are active, and if that is the mechanism by which the chemotherapy enters the tumor cell via the insulin receptor, that's going to be the point when all of these receptors are active. We administer dexamethasone, one of the first medications after the insulin. We do that to lessen the chance of an infusion reaction, something that I haven't seen happen, but we use dexamethasone with every patient. It also, in some tumors, has its own anti-cancer properties. So we use dexamethasone. We also administer a drug called DMSO, which is FDA approved for bladder cancer, but it's also used for its ability to increase permeability of the tumor cell to the chemotherapy. And we administer diflucan because of its ability to increase blood-brain barrier permeability to the chemotherapy. And then we administer the chemotherapy drugs themselves. Usually we're using paired drugs that act on the tumor cell via a different biological mechanism, preferably that don't have overlapping side effects. Sometimes we'll use 3 drugs, but usually it's 2 drugs. We'll administer those, and then after that goes in, we'll have the patient eat lunch. And usually that's a ketogenic lunch, high protein, low carb, and we observe their blood sugars return back to baseline, what they were when the patient came in. If they do not come back to baseline within that time, we may administer a small amount of concentrated glucose to bring the blood sugar up to normal. Patient then goes home. Takes about 2 hours, sometimes 3, depending on the infusion time for the chemotherapy drugs. And then we repeat that on a weekly basis. Now, if the patient is also doing things like high-dose vitamin C, or infrared sauna, or hyperbaric oxygen, we do that on a different day. Vitamin C can interfere with how some chemotherapy drugs do what they do, so we separate that by a minimum of 24 hours. Administer vitamin C different day, and then again, we'll do this weekly for 10 weeks. And at that point, the patient will take a 10-day or 2-week break, and then I'll repeat their staging scan, again, depending on the tumor, to determine where we go from there. If I'm getting a really robust response, then I'll, if the patient is getting a really robust response to their chemotherapy, often we can go to every other week treatment for 2 to 3 months. If they're still responding well, we can go to once a month. How often or how long treatment lasts largely depends on what kind of tumor, what the purpose of the chemotherapy is in treating the tumor. Some patients get what's called neoadjuvant chemotherapy. They're getting chemotherapy in preparation of a definitive curative procedure like surgery. In those patients, our goal is to shrink the tumor such that they're essentially downstage. If they're stage 3, maybe we can bring them to a stage 2, or stage 2 down to stage 1, where on surgery, we may find that certainly a tumor is smaller, there may be fewer lymph nodes involved, if any. Another goal of chemotherapy, if someone is not looking at neoadjuvant chemotherapy, but if they're looking to, say they have stage 4 or late stage 3 disease, those patients, our goal is to control the tumor in the least toxic manner possible. It doesn't serve the patient to, in many cases, to treat their tumor if it's widely spread. There isn't a cure. You can't cure a patient with stage 4 cancer with chemotherapy. It's not a cure, and that's an important thing to note, because I know that there are doctors out there that are claiming that they can cure stage 4 malignancies, and it just simply isn't the case. Our goal really is to control the tumor so that the patient's quality of life is maintained or improved, so they will go about their lives and not be so adversely affected by the presence of the tumor or the treatment for the tumor. In those cases, they will get scanned periodically based on the tumor type, and their protocols may vary over time, but a patient with stage 4 tumor is going to need to be on some form of therapy more often than not, because when they're not under some form of treatment, the tumor will grow, and when they're on effective treatment, it will shrink. So it's not like they come in and get one shot and they're going to be well. It just doesn't work like that.
Wonderful. Thanks so much for this detailed explanation. Gary, we're here at Gentle Wellness Center, one of the few clinics in the country that implement this type of alternative cancer therapy. And we have patients from all over the country coming to our practice, mainly from the East Coast, up and down the East Coast. We have patients coming here. We also provide quite a bit of assistance with regards to logistics, how to come here, where to stay. We do a lot of hand-holding as far as coordinating and assisting patients, not just with the logistics, but also things like how to finance these types of treatments, and not just for the patient, also with regards to assisting them with their family members that want to come along with them, where to stay, how to commute here to our location. And so I would advise patients to call us for more information. And thank you again for this opportunity.
So that was all great stuff, all great stuff. I did have 2 questions. that popped up in my mind. So for the hyperbaric oxygen chamber in the sauna, um, what determines when you go that route, or is it all inclusive into the vitamin C? So you start with that. Is there like a set system? Okay, if this we see this, we go here. If we see that, we go here, or is it all together? Like how does that? How do they all three of those kind of play?
In cancer treatment, the far infrared sauna and hyperbaric, they are for improving quality of life. It's a subjective thing. It's not that those therapies aren't going to do anything directly to the malignancy. Uh, some of the modalities we employ may strengthen a patient's general health or their immune status, but what patients, when they're doing the hyperbaric or far infrared sauna, they will feel better. They'll be able to tolerate therapy much better. We have some patients who choose to do conventional therapy but want to do something to keep their strength or their health up while they're getting conventional therapy. If their oncologist is okay with them using alternative therapies to mitigate side effects, then we'll certainly will do that. Again, those therapies aren't, it's not like do one or the other. You would do the alternative therapies, again, meaning the hyperbaric and the far infrared sauna, to maximize what's healthy about them while they're getting the more aggressive therapy to hit the malignancy. Those things shouldn't be considered an alternative. They're supplemental, that's the right word to use. They're supplemental to the more aggressive therapy. They're not, they shouldn't be considered replacements.
Okay, cool. Okay. And then the other one was about the supplements, because I think that's a lot of value for anybody watching. That's something they can do now just to
Right.
help them in their life in general.
Well, yeah, and we need more research to tell us. I mean, supplements. You know, you always read billion-dollar industry with, you know, and the commercials will come on telling you how this will help you with XYZ problems, but then there's an FDA disclaimer saying this product is not designed to cure or treat anything. They say that because there's precious little research documenting whether or not these supplements are helping or not. The supplements that we recommend, I look for some level of evidence that will support their use. Now, in alternative therapies, one of the downsides is often there isn't a great deal of high-level evidence, meaning a double-blinded, placebo-controlled study of 1,000 patients or a meta-analysis of 10 of those to decide if a certain protocol is V1 or not. In cases of medicines like LDN, there is a clinical trial, albeit small, that showed evidence of efficacy in one tumor that should be applicable across many tumors, something that is not going to bankrupt the patient and has few, if any, side effects. So there's very little to argue against using a medicine for which there is some clinical evidence of its use. Many of the supplements are used because they are gleaned from 3,000 years of experience that the Chinese have had. That's while that's not, it's difficult to equate that with a large study, well-designed study. You shouldn't ignore 3,000 years of this is the way we've done it, and this is why we do it is because it's worked. That is a level of evidence, and I don't ignore that. Where it gets, where I get picky is if there's some chance of a given supplement harming the patient or interfering. Now, that's one drawback of many of the supplements that are out there is there haven't been any studies for many of these products. Do they interfere with the treatment that the patient's being given? And that's sort of a decision that the doctor and the patient need to decide on, because when it's unknown but the patient does feel strongly about being on a given supplement, if I can't find anything that clearly says they shouldn't do it, then we'll agree to doing that, and follow the patient along. We do have an ND, a naturopathic practitioner that assists with that. My knowledge in medicine is greater certainly than my knowledge of supplements, and his knowledge of supplements is greater than his knowledge of medicine. So if you think of a Venn diagram, we overlap appropriately for our patients in that area. There is, let me push one app. I don't have any involvement with the Sloan Kettering Memorial Institute there, but there is an iPhone app that's called About Herbs, HERBS, which has a database, well-researched database of supplements that any patient out there would probably get a lot of information from. It talks about, not only does it provide references for recommendation of a certain supplement, they'll talk about how it works, where it's been used, and what medications it may interfere with. So I use that database as well.
That's really good stuff.
About Herbs. I don't know if there's an Android version of it or not.
Okay, I'll check and then put a link in the description for people, for those who are interested.
Mm-hmm.
But so David, did you have anything else?
Nope, that's all I had. Thank you.
Okay, so hopefully everyone enjoyed that and you learned a lot. So if no one has anything else to add, I think we're good to go.
Wear your mask.
Yeah. Oh, yeah. Wear your mask.
Mm-hmm.
Wash your hands.
Wash your hands. All right. Wear your mask. Stay at home.
Yeah. Stay at home. Wear your mask. Wash your hands. Very important right now.
Good.